Hi, Mrs. Doe.
Yes.
My name is Lauren Bradford. I'm a PA student with the University of the Cumberlands. How are you doing today?
I'm doing great.
Good. If you'll excuse me, I'm just going to wash my hands first.
Okay.
All right. And before we get started, could you verify your first and last name for me
Jane Doe,
and your date of birth?
9/27/93.
Okay. And let me go ahead and look at your medical record number. All right, that matches up. All right, the reason why we're here today is for an abdominal exam. So before we get started, do you need to empty your bladder?
I don't.
Okay, and for this exam, we're going to be using good lighting. And I'm going to go ahead and have you start by laying down supine.
Okay.
Put this up for you. And I will get a pillow for behind your head. Alrighty. There we go. Okay, and I'm going to have you lay your arms down at your sides. And I'm going to have you go ahead and lift your shirt up, and I'm going to drape the patient from the xiphoid process up and the symphysis pubis and down. So I will go ahead and get started with that. And at this time, I'm going to be warming my hands and my stethoscope before I begin the exam, and I'm going to be on the patient's right side. So first, I'm going to start by inspection, and I'm going to identify all the 4 quadrants. So we have the right upper quadrant, left upper quadrant, left lower quadrant, and right lower quadrant. I'm going to be inspecting the skin for any scars, striae, dilated veins, masses, rashes, or any ecchymosis. I'm going to be looking at the umbilicus area for any hernias or inflammation. And I'm going to be looking at the contour of the abdomen, noting whether it's flat, rounded, protuberant, or scaphoid. And also at this time, I'm going to be checking for symmetry, which it looks symmetrical, and noting any visible organs or masses. Also, when looking at the abdomen, sometimes you can see pulsations. The pulsations would be increased if the patient had an aortic aneurysm. So next we're going to move on to auscultation, and I'm going to be listening for the bowel sounds first. I will do this before palpation and percussion because I don't want to alter the frequency of the bowel sounds. And I'm going to use my diaphragm of my stethoscope and listen in the right lower quadrant. All right. And next, I'm going to be assessing the artery regions for any bruits. So I'm going to listen in the aortic artery region, renal, iliac, and femoral. So I will begin now. And I will do a femoral region as well. All right, don't hear any bruits. And now I'm going to be listening for friction rubs over the area of this liver and the spleen. And if I heard any friction rubs, that could be a possible hepatotoma, pancreatic carcinoma, or a gonococcal infection. Okay, that ends the exam for auscultating. So next I'm going to do percussion. I'm going to lightly percuss in all 4 quadrants first to denote the distribution and amount of gas or any masses in the abdomen. And I'm going to do that in all locations. It should be a sound of tympany. That should predominate, and my percussion will guide my palpation for the next exam. Okay, and next I'm going to percuss the area of the liver and the gastric bubble. It's going to be on the anterior part of the chest, just right above the costal margins. And when I percuss on the right, I'm going to hear dullness, and because of the liver, and when I percuss on the left, I'm going to hear tympany because of the gastric bubble. Next, after percussion, I'm going to move on to palpation. So first I'm going to do light palpation, and I'm going to work in horizontal plane with my hand and my forearm, and I'm going to just lightly palpate in gentle dipping motions with my fingers together, right flat on the abdomen. I'm going to gently pull up off the skin. And I'll do that in all 4 quadrants. And at this point, I'll be asking the patient if you have any tenderness. Do you have any tenderness? Checking for any tenderness, masses, noting any muscular resistance. And I want to distinguish if it's voluntary guarding or involuntary guarding due to a muscle spasm by just helping the patient relax during the exam. So next I'm going to do deep palpation, and for that sometimes you need to use 2 hands, and I will do that in all 4 quadrants again, and this is used to delineate masses. Alright, that is it for palpation of the abdomen. Now I'm going to move on to the liver. For the liver first, I'm going to identify the borders of dullness for it. So first, starting with the lower border of dullness, I'm going to begin by percussing in the right lower quadrant under the umbilicus and moving upwards towards the liver. And this will be on the midclavicular line. Now that I found the lower border of dullness, I'm going to check for the upper border of dullness. You would start at the nipple line and work your way down towards the liver dullness. So I begin by percussing downward. And I would mark that area once I find it. And the vertical span of the liver and the midclavicular line is usually about 6 to 12 centimeters. So after I do the percussion, I'm going to check for tenderness of the non-palpable liver by placing my left hand on the right rib cage and strike with my fist and see if the patient experiences any tenderness. Tender? Okay. And I'm going to compare sides. Tender? Okay. And once I'm done with that percussion portion, I'm going to palpate the liver. So I'm going to do this by placing my left hand under the patient's back, and I will be supporting the 11th and 12th ribs. And I'll place my fingertips just lateral to the erectus muscle, and I will be pressing in and up towards the liver. And I'll have you go ahead and take a deep breath in. Okay. All right, you can breathe now. And when doing so, I'm just feeling for the edge of the liver, and you would feel that 3 centimeters below the costal margins along that midclavicular line. So now that I am complete with the liver exam, I am going to move on to the spleen. So first, when talking about the spleen, if the spleen is enlarged, it will be angled anteriorly, medially, and downward. And the tympani of the stomach and colon will be replaced with dullness. So I'm going to begin with percussion of the spleen, and I'm going to start in the anterior chest, the lower portion, and I will start from the area of cardiac dullness at the 6th rib and work my way over to the anterior axillary line and down to the costal margin. So I'll go ahead and do that now. And this area is termed trough space. I hear tympani in this area, which is indicative of a normal size spleen. So now I'm going to check for the splenic percussion sign. So I'm going to place my finger in the lowest most interspace and percuss. When doing so, I hear tympani. So go ahead and take a deep breath in. Okay, you can breathe again. And I percussed again in that area when she took a deep breath, and I still heard tympani. So that means that the spleen is probably normal size. And also, when I am percussing, that can suggest an enlarged spleen, but that doesn't mean for sure. The actual palpation of the spleen will confirm it for me. So now I'm going to palpate the spleen. I'll place my left hand around the side of the patient, supporting the ribs and pressing upwards. And I'm going to place my fingers below the costal margin, and I'm going to just deeply palpate and have you take a deep breath in. Okay, you can breathe now. And right there, I was trying to feel for the tip or the edge of the spleen. So I've completed the exam of the spleen. Now I'm going to move on to the kidneys. Now the kidneys are retroperitoneal, and they're usually not palpable, but I'm going to go ahead and begin by going to the left side of the patient and palpating for the left kidney. So I'm going to place my right hand behind the patient, and I'll have my fingers right at the costovertebral angle, and I'll have my left hand in the left upper quadrant, and I'm going to palpate for the kidney. Okay, and when doing so, I was pressing anteriorly with my right hand upwards. Now I'm moving back to the right side for the right kidney. At this point, I'm going to place my left hand under the patient with fingers at the costovertebral angle. I'll have my fingers in the right upper quadrant, and I'm going to begin by palpating for the right kidney. Okay, so now I am going to have you sit up, and I'm going to percuss for tenderness along the costovertebral angle. And I'm going to use the ball of my hand and percuss and strike with a fist. Do you have any tenderness?
No. No.
Okay. All right, you can lay back down. All right, and that was everything for the kidney. So I'm going to go ahead and move along to the bladder. And I'm going to be checking for bladder distension. So I'm going to begin by palpating above the symphysis pubis. And if it was distended, it would feel round and smooth. And I'm going to be checking for tenderness here. Do you feel any tenderness? Mm-hmm. Okay. And next I'm going to be percussing, and I would only feel or hear that dullness if the bladder had 400 to 600 milliliters of fluid in it. So I'm going to go ahead and percuss the bladder. All right, so next I'm going to test for the width of the aorta. So I'm going to have my hands, both sides of them, in the deep upper abdomen, left of the midline, and I'm going to just place both of my hands down and try to press deeply and feel for the pulsation of the aorta. Okay, I feel that. And the normal width of the aorta is 3 centimeters. So after that, I'm going to be testing for some things, and first testing for ascites. So shifting dullness is the first test. If the belly did have ascites in it, I would go ahead and have you turn to the side for me, please. And that fluid would move downwards. The dullness would shift to the dependent side, so I'd feel dullness down here, and then tympany would move to the top. You can go ahead and lay down. Now I'm going to test for the fluid wave. I'm going to go ahead and have you, as the patient, place your hand in your mid-abdomen, and I'm going to place one hand here, and I'm going to tap the flank, and I would feel an impulse if the patient had a fluid wave, and I will do the same for the other side. Okay. And next, I'm going to be testing for a possible appendicitis. So there's many tests you can do to determine this. First is ring-bound tenderness. So I'm going to place my fingers down here in the right lower quadrant near the McBurney's point and press down deeply and lift up. If the patient were to feel more pain while lifting up, that's a positive for rebound tenderness. I'm going to test for Robson's sign now. So I'm going to place my fingers firmly in the left lower quadrant and press. If the patient experiences pain in the right lower quadrant, that is a positive Robson's sign. For the psoas sign, I'm going to place my hand above the patient's right knee and go ahead and lift your leg up. Okay. If the patient experiences pain while doing so, that would be a positive psoas sign. Now for the obturator sign, I'm going to have the patient bend the knee, and they will be flexing at the right thigh, and I'm going to internally rotate the hip. If the patient experiences pain when doing so in the right hypogastric region, that is a positive obturator sign. So now I'll test for possible cholecystitis. So I'm going to test for the Murphy sign. So I'm going to place my fingers just right under the intercostal margin, and I'm going to go ahead and press in, and go ahead and take a deep breath for me. Okay. All right, breathe out. Did you feel any tenderness? Mm-hmm. Okay. If the patient felt any more pain or stopped upon inspiration, that would be a positive Murphy sign. Now I'm going to check for ventral hernias. Now ventral hernias are usually in the abdominal wall, and they're exclusive of inguinal hernias. So I'm going to go ahead and have the patient lift your shoulders and head up. And when doing so, if she had a ventral hernia, I would see the bulge of that hernia. So to further check this, we want to know if the bulge or the mass we are seeing in the patient is intra-abdominal or abdominal. So go ahead and strain down for me, and I'll be palpating that mass or anything that I see, and you can stop. And when the patient contracted the muscles, if it obscured the mass, that would mean that it was an intra-abdominal mass. All right, so I'm going to go ahead and take this off. This concludes the abdominal exam. I'll put this down for you. And do you have any further questions for me today?
I don't.
Okay, great.
All right.
Thank you so much. Have a nice
Thank
day.
you. You too.